Good evening, everybody. Welcome back to part 2 of the BACD week. We're going to get Sam on tonight and we're going to talk through some porcelain. Straight in.
Hello.
How you doing? Oh, my headphones have just cancelled off for some reason. Are they back?
Can you hear me?
Oh, I've got them back on. There we go. Slightly little technical glitch. How you doing, my man?
I'm good. How are you?
I'm really well. Have you recovered from the weekend yet?
No, not really.
I'm having like 2 coffees in the morning. I'm still needing a third one by lunch, but we'll get there.
But how good was it?
So
It was
good.
so much fun, and it was so nice to see everyone again, like the whole community, and so many new faces. I think that was your first one, right?
That was my first one. So yeah, absolutely. So everyone was a new face to me, which was great. But as you know, as with all these events, as we started off, and straight in, Iman there saying, "I look taller in person." Thank you so much for that. I hear that a lot. I don't know what's wrong with this camera angle, but I'm going to start getting like a 6'2" ruler or something. But hey,
But how good is that? Look, so she's only seen you on social media, but now at BACD we all met, and this is what it's all about. That's why I just bang on about BACD so much, and others like Simon and people do as well, because that is where our community is. Well, especially in cosmetic dentistry, anyway.
100%, and it was the biggest one yet, right? This year was the biggest conference yet.
I mean, numbers wise, it was good. It was roughly kind of what it should be,
Excellent.
But it was fun. It was fun as well as educational. We all learned a lot, right?
Of course, yeah. We learned tons.
And you're presenting next year, so I'm looking forward to that.
Oh, I didn't even get that plug in. You beat me to it. So yeah, next year is going to be an even better program because there's some dentures on the menu. So that's exciting, right?
Exactly.
But yeah, super excited to come and do that. That'll be awesome. But wow, now that we've already gone BACD, everyone can assume that you're involved with that. But do you want to just give us maybe a little introduction about yourself for people that maybe don't know who you are for some reason, and then we can jump on and chat some veneers.
Yeah, sure. So, well, thanks, Rupert, for inviting me to this. I feel privileged given the list of incredible names you've had on here before. So thanks for putting me on that. Who am I? Well, my name is Sam Jethwa. I'm a general dentist. I focus on indirect minimal preparation porcelain veneers, rehab cases, any indirect work generally, multiple unit cases. Tend to see the patients who in the clinic who have either neglected their teeth for many years and have kind of a no hope situation, and we're sort of saving things, and that's why we've got a multidisciplinary team: periodontist, endodontist, surgeon, implant, and Gers. Semi, you should get him on this because the stuff that he does is just amazing, and it means that our patients can get results when they've otherwise been told there's no option. And generally, I also tend to attract the really high detailed patient. And all the stuff that comes with that. So
that sounds fun, yeah.
and that's the game that we're playing, and we've got to know how to play it, and that's kind of the area of dentistry I work in. BACD, I'm director of communications. I've been one of the board members for a few years now, but that is where my journey started in cosmetic dentistry. It was all about BACD at the beginning, back in 2000 and probably something like 10 or 11. When I was still a student just about to qualify. It was kind of, what do I want to do? I always knew cosmetic dentistry was where I wanted to be, but I just didn't know how to get there, or like, what do I need to learn, and what courses do I have to do, and all that sort of thing. And that's what was my guide, So, and here we are.
That framework to do it. It's a very similar story to Simon's as well. So that kind of period as well, as a student.
Yeah, exactly the same. Simon was in my year, so we've been good friends ever since university. Yeah, and very, very similar journey. Obviously, we chose slightly different clinical paths in the sense of he's focused on the digital a little bit more than I am. I mean, that's the last, I'd say, 10 years. That's kind of been my pathway, just being guided by the people around me at BACD, really. And I'm so thankful for it.
Absolutely. I mean, and I say my first time at conference, blown away, and yeah, I'm 100% getting more involved. Not just because I'll be speaking. I can't have my non-member badge when I'm speaking. That'd be a nightmare. But no, I loved everything that it was about. I think all over it. got loads of people on, which is great. Dinesh is saying hi. We've got the Northeast Best Young Dentist, private dentist from 2021.
Oh, wow.
Denturelux is saying hi as well, so no pressure. And Dr. Mike Gray's here as well. Good man. So man, let's jump into some veneer stuff. We generally try and run these as sort of a 3-stage bit and basically a workflow. So we'll cover a bit of assessment first, and we had tons of questions. Thanks, guys, for writing in. We were just recapping them before we started. I'm pretty sure it's the most questions we've ever had, even more than Finlay Sutton on a denture page. So good man, you're doing good. So in terms of assessments, though, this wasn't a specific question, but it's something I quite like to sort of ask is, do you have a certain layout for your assessments? Say what you're doing is sort of more these cosmetic cases, but you say you're general dentist, so have you got a specific sort of consult pathway that you follow?
So the first thing to say on that is I have a whole team around me. Before the patient gets to me,
give us the journey.
Yeah, they will have gone through. I wouldn't call it a vetting process, because I know that's what some dentists will. It's not that. We don't vet our patients to see like, well, can they afford us, or that sort of thing, because we want to be accessible, and sometimes we are the only hope, and so we've got to have that openness, and we will always find a solution for people who have a budgetary constraint or something like that. We'll find some way of helping. So that all begins with our treatment coordinator. So our patient care coordinators, some have clinical backgrounds, nurses who've kind of trained to do this, some non-clinical entirely, but have worked very closely. And so we really want to get as much information from the patient as possible to see how we can help them. It's not a sales technique, it's purely a way of ensuring that we're a good fit, right? The patient may at the end of that phone call feel that, sorry, this isn't the right place for me. Maybe that's budgetary, maybe it's just a connection, they didn't feel it, or maybe it's a distance, we're just too far. I mean, we see patients from all over the world, but generally anywhere in the UK. So there's got to be that initial conversation, because sometimes our diary time is precious, right? So we can't have it with consultations coming in and it's just not the right fit for them. So that helps. It really, really helps.
Is that something you've pushed on more since COVID? The sort of the rise of the tele consults or anything, or has this always been the pathway?
We have always had this as a pathway, but we have increased it virtually. We now have it standard as virtual, whereas before it was standard coming in and you could have a virtual. Now it's virtual and come in if you want to. Right. And we prefer people to come, because that is how we can really be able to really truly understand someone. On a video call we can have a conversation, but you don't get that connection, and so we do like that. So that can be phone call, that could be an in-person visit, that could be a virtual consultation. There's no fees associated with any of this. It's purely there so they can understand more about us and we can understand more about them. So that's the beginning. From that appointment, what will happen is the patient will be, by the treatment coordinator, directed towards the dentist that is in our practice most suitable for them. So we don't really have a lot of overlap between what our associates and I do. We all have our specific areas, which I think is the right way to do this level of dentistry, because we're not dipping our fingers in a bit of this, a bit of that. I have done everything in order to get to where I am now and know what I like and what I'm good at. And the dentists that I'm kind of hiring, who generally have been through our training pathway anyway, we kind of get a feel of what they really like, what they want to do. And at the beginning, if they join us, that's the conversation we're having. So we see means that the patients see the people that are good at what they need treatment wise, and also the dentists enjoy what they're doing, so no one gets bored. And a lot of patients will come to the practice for me, and then it's maybe not a case for me, and then they'll go somewhere else. So it's about introducing those other team members as well. Then they'll have a consultation. Now, these consultations can range from around about half an hour up to 2 hours. I'll generally have for a big rehab case or a complex. When I say complex, generally, when we say complex case, what is a complex case? In my department, it's an expectation management, which was how complicated this case is going to be, because clinically we know we can manage it. It's a case of when a TCO says to me it's a complex case, that means you need 2 hours with this patient because the expectation management and emotional side is really needing that your time. So if I have 2 hours with a patient, you know, that's sometimes not enough. By the time we get to the end, we've figured out treatment plan, set the expectations, figured out what teeth we're treating, how we're treating them, the whole plan, and then that's presented. And then we decide if we're going to do it or not, or whether we need to see them again for further information, or whether it's now going to one of the specialists for perio or endo or this, that, and then come back for another treatment plan. So generally that's the workflow. And by the time someone goes through that, there's very little trust that hasn't been built. They've trusted the team members, they've trusted me, they can see our work, they can see kind of how we do things. And then if they feel that they want to proceed with something, we'll try to take it as baby steps. We're not one of those salesy cosmetic practices that wants, you know, to make the sale and get the big cases. It's the opposite. We just want to do the right thing in steps. And if it means one thing at a time, then we'll do that. So we do a lot of training with the team on personality types, how to deal with different people, because you can imagine the kind of people that we're attracting are often finding it difficult to trust a professional, either because of previous experience or anxiety, and because of the significant financial investment they're making. You know, I'm like that. If I'm doing anything that I consider to be expensive or an investment, I will ask multiple companies. I will ask really probing questions. I'll be quite difficult about it all, not because I'm, you know, just a difficult guy. I'm actually pretty easygoing. It's just because I want to know I'm making the right choice. No one wants to make a mistake. And the only way that we can show our patients that is time.
Yeah, and this is something that was one of the questions as well, and I'm sure we'll cover more as we go through the steps. But you know, expectation management and stuff with this kind of work is really going to come into it. Karina's here, by the way, and she says hi, boss. So best behaviour.
Karina's our dentist.
You've got them through this sort of quite extensive sort of pre-pathway, and you know, you say you come into a case, and we're going to talk veneers now, narrow in on that. So what kind of things are you looking for in terms of treatment planning? So there's lots of questions that we've had, you know, so you know, obviously the gum work, you know, is there, you know, prep, no prep, align, you know, what kind of things we're looking at. So if you have a sort of rough idea of a checklist that you look at to sort of go through a case and determine these things?
Yeah. So obviously, other than all the health elements, we will have photography, we'll have x-ray. So we'll have the general basic information that we need. Then when we have the patient in front of us, it's really about understanding their expectations before we even look in the mouth. I want to know what their goals are, what aesthetically, and also what's their motivation for it. Because having done this for long enough now to have learned things the hard way, I spend so much time now trying to figure out the emotional and psychological motivation for treatment.
For why?
Yeah. And often you wouldn't believe some of the motivations actually are not what you think they are. It's not, oh, I just want to look nice, or this a photo. It's actually deep, way deeper than that. It's about some trigger 10 years ago, or someone said something, or you suffered a loss, you know, and you think that this is the answer. Seeing the dentist for cosmetic treatment is the answer. Oh, that's going to make me happy. Cosmetic dentistry doesn't make people happy. And that is what we have to figure out at this stage. And because of the kind of level that we're at, we do attract sometimes patients who have that kind of motivation. And it's not about us saying no, it's just about us kind of doing that assessment, asking the questions. So I'll figure out that stuff first. Once we think, okay, there's definitely a reasonable level of expectation here, it's fine, we can manage it. Then I go into the clinical aspects, and the starting point is really the face. I need to assess from a facially driven point of view.
I think that's really interesting, though, and I think that's a really important point, because, as you say, you're sort of saying there that the expectations you might not meet, not because you've not done really nice teeth, but it's not had that psychological or whatever emotional effect on the patient. So you could do the best job in the world, essentially what you're saying, but it's not got to that deep-seated reason. It's never going to, and you could do a great case and end up with an unhappy patient. I think that's a really important thing. Any tips to get into that sort of conversation?
do you know what? It's probably only in the past couple of years where I feel like
That it's
I am
twigged, yeah.
getting there. And so that's why if you ever hear me lecturing or talking about this stuff, I will really go into emotional management quite a lot. And that's something we're going to be I'm learning a lot more myself, but it's tough. And I think the most important thing is there are things that I will say, and I'll say in a certain way, and trying to keep the control of the case. And that has come from making the mistakes, right? So not saying things in the right order, not saying things in the right way, forgetting to say that, booking the appointments in a certain way, and making sure the reasons for those appointments are made really clear. And it's about phrasing things. It's about turning people away and saying, I'm going to help you to overcome these emotional issues and you come back to me in 3 months' time. So I work quite closely with a clinical psychotherapist, who's actually a patient of mine as well, who's been through the process, but he helps people with all sorts of anxiety issues and other things like that. And he's in hypnosis. We don't use the hypnosis side, but he helps us to figure out, or helps the patients to figure out, how they can get into the right frame of mind before we do cosmetic treatment of this kind of dramatic cosmetic treatment. So there's no answer. It's time, it's experience, it's making the mistakes, and it's about being aware and kind of you get it when the older you get, and the more cases you do, the more you are not afraid to say no. Let's do this first. Let me help you with this a little bit. Speak to this person. Come back to me in 3 months. I don't feel you're in the right place for it. And if you go and see another dentist and they say, yeah, go ahead and do it, all my advice is don't rush into it. I don't think it's the answer to what you're looking for right now. It's hard to say that to a patient, especially as we get enthusiastic and want the cases. And sometimes amazing cases come in and you know exactly what you're going to do with it. But if I have that little bit of doubt in my mind, then I will work on this emotional side. I mean, this is like another whole live. We should probably move on.
There we go. Part 2. We've got it. We've got the part 2.
There is so much
for the new year.
So much on that.
My fault for sidetracking. I just thought it was a really, really good point. So let's jump back. You were saying it's all about the face. So talk to me. What are you looking at? What are you analysing?
So the first thing, that we want to do, and obviously we all think this when we're doing anything cosmetic, is facially driven treatment planning, right? So traditionally, and you may know that I'm not a fan of traditional veneers, Hollywood smiles. That stuff is not my bag. I don't like it. I've said that quite openly out there before. I feel the Hollywood smile is dead. I don't like that look. And if you want that look, don't come to me for it. That's really quite clear. I don't generally attract those patients who want that because they know that's how I feel about it. So what I'm trying to do is trying to create the most aesthetically harmonious result for that patient. So I want to give them perfection, but their version of perfection, which is why there's probably a video of me, there is a video of me on Instagram ranting about what's natural and what's perfect. And I believe it's the same thing. Because really what's perfect for someone is what looks most natural. So for example, like let's say Stuart Beggs, who's incredible at his posterior work.
He's on
right?
here, don't
so
Stuart, too much.
your posterior work is emulating nature, right? That's where that whole thing comes from.
That's a good name for a course, emulate.
Yeah, weird that no one's thought of that. So when you're emulating nature, why are you doing that? Because nature put those shapes in place as a result of what's working, what's functional, right? So when you're creating those functional cusps, you're creating those fissures, they're all there for functional reasons. So that's natural. Therefore, it's perfect. What's the most perfect posterior crown? It's not one which is flat, occlusal surface and all that stuff, is it? That's not perfect. So why is it that when we look at anterior work, we're thinking of perfection as Hollywood? Right? That doesn't make sense. So if we translate that emulation into anterior work, then really what we're talking about is trying to create the most aesthetic result for the patient that looks like their teeth, but the best version of their teeth. And the answer to that is to look at their face. How are we going to use their asymmetries to our advantage? So the first thing I will look at is, I've got a case here. I'll flick.
Go for it.
How do I do this?
if you tap, there should be a little flip on the bottom or
Oh
middle or
yeah,
somewhere.
got it.
We've got a little interesting question there, which we can answer at some point. From Dentures by David Hingley. So it is from a denture point of view. So very interesting. Do you guys ever ask patients to bring partners or family members and things? That's the old denture adage, isn't it? So we love doing that.
Okay.
You get the old dude in and get the wife in because she's the boss, and he goes home and goes, oh, she doesn't like it. So do you ever gauge that? And at what point do you gauge that?
This is interesting. This is on that what to say, when to say situation. Okay.
Yeah.
So as most people listening to this probably know, I'll create a handcrafted trial smile. I don't use wax ups for cases.
Oh, there's lots of questions about that. Don't worry.
Okay. So I'll create it fully by hand using flowable composite. So when I do that, I'm creating what I know looks good, and I'm not going to leave it until I'm happy with it. So the patient will go with my version of what I think is right, based on my understanding their expectations and kind of what they're looking for and all that stuff. But then I'll kind of do what I know I want to do, rather than just listen, right? Because really I know. So before I give the mirror to the patient, I will say, and if anyone has been on my course, this is a big part of our day 4 of trial smile review, or just this is what we say, and I say, you're not going to like what you see. When I give you the mirror, don't force yourself or have the expectation that you're going to like it, because you probably won't. And then if you have that expectation and then you don't like it, you're not going to like me. And I've just spent 4 hours crafting every single tooth from scratch. And I'm not going to be happy with that because I've tried so hard. My nurse and myself know it looks good.
Yeah.
If you went in and you dyed your hair another color, or you got a different style, it may really suit you. It's going to take you a week to get used to that. It's quite normal. If a dad who's in his 50s has had a beard his whole life, his kids are young, and he takes the beard off, then they're going to be like, that doesn't look like you, daddy, right?
Yeah.
So that's the situation that we're dealing with. And so that takes, your mind will take at least a week. Some people are quicker, some people will take longer, but at least a week to catch up with this. So if you show someone a before and after of their smile, they'll say, oh, that looks amazing. And you give them the mirror, it's like, so all those mirror reactions, you probably see I don't do many of them, because most of the time I don't get that reaction. I know the patients who will give me that, and then we'll ask them if they will film it. But most of the time it's okay. So if you wait for that reaction and then you say to the patient, don't worry, it's new, you'll get used to it, you're on the back foot, you're trying to then defend your work. Yep. No one's listening. The patient's not listening to that. It's just, or he's just trying to say that to make me feel better. Yep. If you preempt it and you say, you're not going to like this, you will like it in a week. When you go home, none of your family are going to like it, especially people with gaps who have the gaps closed, small teeth have the teeth made bigger, anything like that. Be aware that the reaction you're going to get may not be positive. Do not let that reaction affect your mindset or what you think. Just let everything go. Don't think about it as much as you can for a week. In a week's time, you'll start catching yourself in the mirror, and all those people who were shocked will stop saying anything, and then they will all look at you, and you'll look at yourself and go, oh yeah, that does look good. So by the time we come to the trial smile review, which is a week later generally, the amount of things I have to change is next to zero. Mm-hmm. It's like I'll spot something, but the time the patient spots something is hardly. And if it is, it's Sam, what do you think if I did this change? And then I'll look at it and think, yeah, maybe we should, or actually, no, because of this.
It becomes collaborative.
And that's the thing. We are keeping the control within myself and the patient. Mm-hmm. And I've already warned them that they're not going to like it. So when they do look at it, they generally do like it. But then they think, God, it's not that bad. I kind of like it. I can see that I'm not used to it, but I can see it. I'm going to like it. So by doing that, and managing that and letting them know that everyone else is going to be shocked too. I don't need to bring people in. The fewer people involved in the process, the better. It should be me and the patient and no one else. Those other people need to just go along with the ride. And really, you're just inviting unqualified people to help. And if you are too responsive, so the patient says, oh, this one looks like this. Okay, let me reduce it. This one is, oh, let me reduce it. You will end up pushing the patient back to where they started, because their comfort zone sits before you started. Even though they don't like that, they're used to it. So what's going to happen is you're just going to reverse your progress. And too many cooks spoil the broth. So I don't ask anyone else. That's what you've got to say to stop that.
That's ace. I mean, let's get back to the face. But no, that's fantastic. I think you know, in my line of stuff that I put on here, you know, I'm doing general dentistry, but you know, I'm showing sort of cosmetic denture stuff. You know, I have the same thing. You know, if you say it before, it's, you know, it's sort of consent or, you know, managing expectations. You say it afterwards, it's an excuse. And 100%, I'm with you on that.
Okay, so
let's assess some faces.
First thing that I'll do. This is my lovely patient. She came to see me, and this was her kind of her natural smile. This is how she was showing her teeth. Okay, so her concern was my teeth look small. My daughter's getting married, and I want them sorted out, and I want them to be sort of just longer and things like that. So the first thing I'm looking at here is, well, generally I forgot to ask her to take the glasses off, but I would take the glasses off and I'd want to look at midline. So I'm trying to look at where's the midline sitting, because, you know, as far as I'm concerned, we've got three midlines. We've got this midline here, we've got this midline here, and then we've got this midline here. That's in the face. And then we've got dental midline somewhere hidden in her case. So we need to see first, from a consent point of view to the patient, which one are we going to be lining up with? You know, dental midline might never meet the nasal. So is the patient going to feel that afterwards, oh, the teeth look a bit off, and oh, actually, was it the nose? So you've got to get all this dealt with at the beginning. So that's the first thing I'll look at. The second thing I'll look at is the jaw shape. Now, we all have something called a strong side and a weak side. A strong side will be one, probably that we use a bit more, maybe it's just the masseter's built out. So if we look over here, can you see how different this jawline is? This is far more horizontal than this. This is much steeper. Okay, so we need to build this side out more than we need to build this side out in order to give this side of the face the dominance that it needs. If we were equal, if we widened her buccal corridors, let's say equally, then one side would still look narrow and one side would still look large. You see how this is slightly more visible over here? Okay, so we need to look at the jaw to help us with that. The second thing the jaw helps us with is alignment of, let's say, the angulation of the tooth, the mesial angulation. So I'm trying to always, if I'm widening someone's smile, I'm trying to see how wide can I take it, but then also how much do I need to bevel things in? Because what you can end up with is you can end up, if you have a narrow face, you can end up with a really wide looking smile. That's too wide. And if you give someone with a wide face and even wider smile, then you could end up with a really square looking face, and it could be, you know, even worse. So you'll end up shortening the lower third of the face without trying to. And if you give someone long teeth has a long face, you're going to make the lower third of the face look longer. So it's all about that initially, and that comes from the jaw shape for me when I'm looking at that. The other thing I'll look at is the lip shape and lower lip generally. Upper lip gives us a lot of indication as to how much thickness we can build, and all that sort of thing, and speech issues or trying to move around the teeth, that kind of thing. But the lower lip will give us the incisal edge and a bit of an idea on that. Now, this is a static image. This is not in itself enough. We need to see the patient doing resting sounds, talking, counting, maybe a little video would help. So you can do that. And you can even start adding a little bit of flowable at this stage and kind of see where you need the incisal length to be and how you're going to achieve that. So that's then kind of looking at the lip and incisal edge. I'll always start with the centrals. You know, this is a basic. We all kind of know that. Start with the centrals, work backwards, and kind of make it work. And that will also help me to identify: do I need to increase this patient's vertical in order to get the teeth to sit at the right level on the lip, or give the patient an increased vertical height here? That kind of thing is going through my mind. And then, you know, then we would focus more on the teeth, and then we would go kind of look at a smiling photo, and we'd see, look, she's got a reverse smile line. We need to fix that. Proportions might be off, and, you know, I don't have the teeth photo there, but that's the kind of thing then I'd be looking at in more detail. So that will come into then gum position. So you mentioned that earlier, and I think we had some questions on that.
Yeah, so there's a few questions about, you know, sort of gum contouring and things like that, and I think this is where I was chatting with a friend who was shadowing a periodontist. You know, he came out and said, well, geez, he's looked at this obviously as a periodontist and said, da, 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 da. He's like, now that I've seen that, I've got so much more appreciation. It's like the final piece of the puzzle, right? It's the framing of the teeth.
Yeah, and actually, it's the first thing I look at, because if we look at this case, we can see that we've got, that's low, that's high. this is okay position-wise in relation to the upper lip, but then we have this issue. So we need to balance it out. Now, I don't want to take this up because that's going to look this up this high, because then they'll be higher than that. And if I take these up, then those teeth are going to look really long, because his correct incisal edge position is probably about where it is.
Yeah.
So I'm now honing in on just proportions and trying to see, where do I take the gum? Because this will frame part of the tooth and this will frame part of the tooth. So incisal edge and this edge is as important as each other, which is why, soft tissue lasers are incredibly helpful. And having a good periodontist who can do some crown lengthening for you is incredibly helpful as well. But this is the first thing I'd look at really for proportion. And then the second thing is incisal edges. Like, where am I going to put that? Angulation, and then width of smile, which we've already have a bit of an idea from looking at the face. So once we've done that, we can go into even more detail and see that tooth looks a lot wider than this one. And how are we gonna correct that? We might need to play around with the reflective surfaces to try and get them to match there, to try and hide that. So the gum is really, really critical. So the question really is, if I'm going to want to increase or reshape a gum line, because that's quite triangular, I might want to round that off, then I need to know where my limits are. And when can I use the laser, and when do I need to crown lengthen, and what order do I do all that in? Well, I think.
And are you doing the laser, or is everything periodontist and your
laser is me.
Yep.
And if it's very, very minor. So over here, that little touch there, that's this is not interfering in biological width. It's just repositioning the zenith of that tooth, let's say, because that's what's going to dictate. If I leave that zenith too mesial, then we're going to really struggle to get that tooth angulation correct. So I'm going to push that back a little bit and then build this out so I can push that tooth this way. So that comes down to the gum. So those kind of minor things, a routine, I'll do it on every single case. If I need to lift this far, then I need to make a decision of, do I crown lengthen, or can I get away with the laser? And the way to know that is to do something called bone sounding. Okay, so we numb the area, we probe right until we can feel the bone. And then we're gonna measure how much we need, and we're gonna measure how much room we have. And if we can identify that we have enough to, if we're going to adjust a millimeter and we've still got, let's say we've got 5 mil up there, then great, you're going to be nowhere near the biological width, you're fine. Altered passive eruption cases, where we've got kind of these teeth that clearly could be bigger, and that's fine, then we know we're not going to interfere with that, and that's okay. This comes with a bit of time, bit of experience, and knowing kind of your limits, but that will always be something I'll consider. So in this particular case, I decided to take the laser as far as I could without damaging anything, and there was a limit. So in the final post-ops of this case, you'll notice that this is still lower. Oops, sorry. This is still lower than this side, but it's just a little bit more balanced, and not obviously, hopefully not as noticeable. But we decided not to crown lengthen, because overall, this smile is very, very wide. And he said to me, I'm not doing that all the time. I don't really want to go through that surgery. This is kind of where it sits normally. And so I'm happy to leave that. And that's fine. I'm happy to compromise on something like that if it means no crown lengthening, no 3 months of surgery and healing and all that sort of thing. Right.
Yeah.
But
we've got a little question there at this point saying, what about ortho to align zenith? So obviously we're probably going to talk about alignment at some point as well, in terms of having more minimal preps and things like that. Is that something you look at with zenith, or something like this is, say, quite minor, it's a quick bit with the laser? Obviously, if they needed more alignment, you'd probably look at doing it more with alignment than anything else, or do you find that's not as reliable?
Okay, so to align zenith with ortho,
tricky,
to the level that we need it, is going to be some kind of genius orthodontist magic, basically. We can move gingival level down, let's say, by kind of bringing a tooth down and things like that. So we could bring a tooth forward, let's say classic lower incisor crowding, right? Gum lines are uneven because the lower is retroclined. Bringing it forward is going to realign that gum line. But often at the end of those cases as well, you'll touch it up with a laser because there is still some excess tissue there. So zenith repositioning No, not with ortho, but overall repositioning, yeah, sure. But to move that there, it's not going to happen. No way. Moving this up here, again, it's not going to happen. The teeth are aligned. We don't have an alignment issue. So, so yeah, I would only really be considering ortho for cases where there is a need for ortho, but I wouldn't be relying on the ortho for my anything perio at all. I'd still look at that again and reassess.
Perfect. Other questions we had on planning. One on material of choice, Emax, feldspathic. Does it vary? And then my one that I've added in, number of veneers. So should we do a bit of materials first?
Okay, let's talk about materials in a really, really, really realistic way. Okay, feldspathic is beautiful. We all know that. It's stunning. Done by a technician who knows how to create beautiful feldspathic porcelain veneers. There is nothing more amazing than that. Sadly, in the United Kingdom, we have a problem. We have a problem where the younger technicians don't have the experience with feldspathic. And sadly, and I don't want to offend any technicians who might be listening, and the more experienced technicians don't like my workflow. So if I want feldspathic, I could go to, there are a few people in the UK who can do it really well to the standard aesthetically that we want, but they won't copy my Charleston in the way I want. They won't put the effects the way I want. They will have over the years developed their own beautiful aesthetic, but it's theirs.
Yeah.
And that's the challenge we have. So trying to get a technician in the UK to do this the way you want, I have really struggled. So what that has meant is that I have tried to get the best out of the materials that our techs feel really confident using, which tend to be, in most cases, Emax, but of course there is a GC lithium silicate material as well. So
it's very BBC of you. Well done. Other brands are available.
Yeah, I don't get any perks from any of the material companies. Of course, I work very closely with DMG because they cannot work without their stuff. But when it comes to the actual porcelain material, I like to, where possible, use Emax cut back and hand layered with feldspathic on lower third, so I can get real translucency, true translucency, not made by blue tints and grey and all that stuff, because it just does not look as good. But you have to choose a case. So if you do that, you are introducing a weak spot, okay, where you've got the pressed Emax and then you've got the layering. You need to have either the occlusion under absolute control, or not choose it for a case which is, a rehab type situation. Then you're probably likely to choose anteriorly pressed Emax without having a bit of cutback and trying your best to make it look good. So these are all initial conversations I will have with the patient and say, in your case, this is what I think. So that's the reality of feldspathic in this country anyway, at this level. So that's what we'll be using. Zirconia, Ivoclar do a new thing called Zircad. Well, it's not new, but it's a material where if I'm using a bridge next to, I don't know if I've got a case here. Let me show you this. So if I show you this case, material-wise, okay, so again, look, gum issues, missing lateral, that kind of stuff, baby tooth, that was extracted. This is a bridge. Okay, so that is actually, that's a veneer on the front of the tooth, and then it's a Maryland on the back in actually Emax. So this is like what the textbooks say not to do. Okay, so I do a fair bit of stuff that they say not to do, but because I understand that I can get the occlusion to work with it, right? So so that way we managed to get the aesthetics to match. But if I had done that in the Zircad next to an Ivoclar Emax, it would be fine. It would look fine. So and then I think one of these is a crown, possibly that, and so that again looks fine because it's an Emax. So we need to have the ability of understanding the material so we can mix and match without them looking different. But the biggest challenge is translucency. So the biggest challenge in using Emax as a material is, and why people say feldspathic looks better, is because feldspathic has that natural vibrancy, whereas to get that out of Emax is really difficult. We manage it, but it's hard.
Without compromising structure.
Well, yeah, it's just difficult to make it look as nice as a feldspathic. So you've got to know how to cut back and layer. You've got to choose the right translucency. So Emax in the basic way comes in low translucency, high translucency, and medium translucency. So where possible, I like to use medium translucency, but it all will come down to what the core shade is. And you can get some results that have to have a bit of low translucency. They're just never going to look as real or as like feldspathic. So, and then if you have too much medium translucency, it's going to look grey. So if you have crowns and they're thick and you want them to look real and you ask for medium translucency, they come back, they look grey, then, you know, that's another issue with the material. So you've got to know when to choose what to do. And I tend to prescribe that to the lab rather than letting the lab decide.
At what stage are you sort of clocking this beforehand, or is it literally you've got the preps there and you're looking at, you know, underlying color or whatever it is? Or what point are you sort of starting to notice this? Most of it you can see. The time when most of it you can see before you start. I will always whiten every case before I start. I know a lot of people who do veneers don't whiten beforehand. I will, because I want the veneer to be as thin as possible and I want to try and use as more translucent as possible. So I will do that. The other thing is, once you've prepped, like for example over here, I don't know what that is going to look like really once I take that composite off. You know, if I was keeping that, let's say that's pretty dark, and so I'm going to need to hide that. So there are situations which can give you an indication. But for example, let's take this replacement veneer case, right? This was the before, and that's her now. And I just wish I'd just done that one. But anyway, you just don't know what you're going to find here. You know, this was her third set of veneers done in 2 years because they just couldn't get them. And I just don't know. So I wanted to make it look real, but it was pretty dark underneath. So I went for low translucency, but we managed to get the kind of good match with the natural teeth just by texture and a bit of cutback. So you know, this stuff is complicated. Color in veneers is complex. It's not, when you look at a BL3, which is as a base and a basic level my favorite color. If you have then a BL3 in LT versus a BL3 in MT versus BL3 in HT and all that sort of thing, it's going to look different. And then what's behind it, and then what kind of cement are you going to use? If it's thin enough for the cement to make a difference, or translucent enough for the cement to make a difference, then that becomes a factor. If it's low translucency, pretty much whatever you use underneath it's going to do nothing. So it's a whole minefield, color-wise. Yeah, absolutely. And in that case there, segues beautifully into that loaded question that I wanted to pop in there about number of veneers. So this is something that my boss, prosthodontist, denture place in Harley Street and all sorts did lots of. And, you know, his mantra is very much you do 2 to 2, or if you want to sort the canines out, you've got to go to the 4s. Otherwise, 3 to 3 never looks that grey. What's your philosophy on it?
All right, well, let's just have a look at some stuff. So this is 3 to 3. Okay.
Yeah.
This is 3 to 3. This is 4 to 4. This is 10.
Yeah.
Okay, so I wouldn't say that any of those cases look particularly bad. I think if we want to go into it, if I look at this case, let me click you back again. If I look at this case, an extra 2 units would be amazing.
Yeah.
Right? Because that would widen that out.
Yeah.
With 6, you have to consent your patient for the smile looking a bit narrow. Because with 6, generally, that social 6 and all that sort of thing that used to be done, you will find that you will build, they will generally underprep and overbuild out.
Yeah. So inherently, you're sort of increasing the pronouncement of the art. Yeah.
What's going to happen is when you have dentists who've been doing this for a really long time, they're very used to the materials needing to have a minimum thickness. And that minimum thickness has now come down quite a lot, okay, generally. So we don't need to bulk out the teeth as much as we used to. and sometimes the prep was too prescriptive. So each tooth was, even if the position was different, the teeth were prepped in the same way as you go along. But each tooth actually, we know, needs a different amount of preparation. Some might need none, some might need a little bit, so that we get this occlusal plane. So traditionally what would happen is you would end up building the front 6 out and they would be looking pretty bulky, and then you'd get a narrow buccal corridor. So that's where this do 4 or do 8 comes from. So it's case dependent. In this case, I decided that she was, she had a budgetary thing. She's like, I don't want to do more than I don't want to spend more than that. I was like, look, we can get things looking really decent and natural for you with 6. I can't really do any less than 6 because that's a bridge and that's a tooth that had to come out. So you'll have to accept that might be a little bit narrow, but that's enough, right? She's happy with that. She said she might do them later, but this was a big deal for her. So she's fine with that. I'm fine with that too because it looks natural. I'm happy with it. Over here, we went from there to there. These teeth are not badly positioned, generally buccal corridor wise. They're visible. Okay, that could be better shaped angulation wise and brought out, but it's not a deal breaker. So I can build those canines out and it'll be okay. So if your canines are, retroclined or coming in, then that's fine. Over here, we've got a premolar that's sitting out a little bit further. And so we know that on this side, that's going to be okay. But if she doesn't do this on this side, it's going to stick out a bit. So it's just about consenting and, does it matter? Do you have to? Do you have to do all those units every time? Well, partly it'll be a conversation with you and the patient, but most of the time there are ways of reducing the number of units and getting their expectations there. Sometimes I will say, you just got to have 10, and if you want to compromise, we can do 8, but you might feel like you want the 2 more later. I don't recommend doing them later because they may not be 100% match. And so that would be the discussion. I do generally say a minimum of 4. I don't like doing 2 centrals. And those who have done my course will laugh at that because I say that a lot. We have amazing dentists in the practice who will spend a lot of time going through all that detail, working with the tech and getting the custom finishes and all that sort of thing. And so, those cases will go to them. But generally I will stick with 4 units or more. Again, 4 is pretty rare. But yes, that I always say, look, even numbers. Generally, if we're trying to be cosmetic about it, of course, every case is different. Sometimes we do. And
is that the same with mix and match of porcelain and composite? Do you maybe do a bit of bonding on bits, or are you just all in?
I'll send the bonding to again the talented girls at the practice, Lydia and Karina. But I will not mix and match porcelain veneers with composite veneers. I will mix and match edge bonding with porcelain veneers because of the lifespan. It's going to be different. The behavior of the material is different. And so those composite ones are going to behave differently and they're going to look different. So if you do 2 centrals in porcelain, do the laterals in composite, when you come to having to change those composites on the laterals and the patient might want porcelain, getting that match is going to be tough. And so I would rather the patient chooses all 4 porcelain than mixing and matching, or you do everything in composite if it's veneers rather than mixing and matching. But quite commonly, I used to do it quite a lot, a couple of canine risers to improve the canine relationship, bonding, and then 4 units, great. Because the canines could be bulky and you don't want to prep them, and the 4 could be built out a little bit to match a canine. So the smile maybe looks a little bit narrow, but not enough to irritate the patient. And you get improving the bite as well. So that's pretty good treatment plan, that 4 units with canine risers.
Perfect. So we finally got to prepping. We could do a whole other thing on occlusion. Maybe that can be the part 2 episode. But you've done your consultation. When are you doing the mock-up? Are you doing the mock-up in consultation? Are you doing it as a whole second appointment?
So this is another controversial thing.
Brace yourself, guys.
Well, maybe it isn't. Maybe people will understand where I'm coming from. I've already talked about the reaction that people have, right, to the treatment. You can help that person. The vision. You see what you could do for them. So every case that we do is built on trust. Every patient will trust that I think the SAM can deliver what I want through conversation, through discussion, through that sort of thing. I do not show patients what things could look like before using...
So no motivational makeup?
No, because to me it's unmotivational.
Yeah.
Because I know the emotional challenges, and I see it happening every case, of what it takes for someone to get used to something. Mm-hmm. So if I give someone a mock-up and in 2 seconds say, oh, what do you think? How does that look? My patients are the ones who will get in the mirror and go, but that's oh no, it doesn't look like me. Oh, I'm scared. You know what? Actually, I'm not going to do it. And you know, what a shame, because I know I can help you and I know I can give you what you want. Yeah. So that's one issue. The other issue is if you are getting a wax up, sending your pre-op to the technician, and we all have well, I don't anymore, but the habit of 4 to 4 wax up, 6 to 6 wax up, 8 to 8 wax, 4 to 4 wax up, 8 units. You know, what does that mean? What does that mean for veneers? I mean, what on earth? What are you trying to achieve? How wide do you want it? Where are your embrasures going to be? You know, are you doing additive? Are you doing a bit of both? Are you putting your gum lines anywhere? The technician has nothing. Yeah. So even if you give a little bit of information, it's still not as much as you would have with the patient in the chair. So you could get a wax up back and you could put it in the patient's mouth and send them off. But when the patient comes back and says, oh yeah, I like it, then you need to control that the technician is going to be able to copy it, that your prep is going to match what that is. And if the patient says, I don't like it, then what are you going to do? Order another wax up. Have 5 or 6. I know dentists who have done that, and you know, oh, we tried 3 wax ups and the patient still doesn't like it. I need your help. Sam, what can you do? And I'm like, well, just bin all the wax ups that start on their teeth, right? So we can't relinquish control of the aesthetics to the technician at this stage. Okay, our talented ceramists come in, but not at this stage, because they can only go off photos and a bit of information. So if they're creating a temporary, then that's going to just be guesswork. Unless you have the ability to put that wax up in, modify that wax up to look as good as you want it to look, and then that can be your trial. So then the patient comes in a week and says, I don't like this, don't like this. You're going to get in there and you're going to make those changes. Then you're going to see them again. That is the power of a wax up, but it's only as powerful as your hands-on skills of modifying the trial, which is how I've ended up only doing them handmade, because what's the point in me getting a wax up, seeing it, and then changing
it anyway?
I'd rather
so your wax ups then, your mock-ups then, sorry, flowable composite, and you said, you know, could be 4 hours this appointment. So just give us a little bit about that.
I would say 4 hours for a full mouth. Generally a 10 unit, we're looking at 2 to 3 hours for the whole thing. But trial smile appointment very rarely is a separate appointment to prep. Okay, so in a rehab case, we would generally do additive. We're building everything up. Let's say really worn down teeth, additive, full mouth, wax ups, posteriors, and then incisal edges everywhere else. And then I will do the facial using flow.
Fine. So there is some plan, but that's more rehab.
More rehab, only rehab, and that's additive. So that's when the prep appointment is separate, because then I'll do those cases in sections, okay? Because that's predictable. But if it's, let's say, upper 10 units, then the process of prep is going to be, initially I would you can do it a few ways. I'll tell you the way I do it. I will know where I need to prep and where I don't need to prep before I start. So I will just get the laser, modify my gum lines, my zenith. I'll then know exactly where I want to prep, where I need to reduce, where I don't need to reduce, and then I'll take my impressions, and then I'll start doing the trial smile. The only way that works is because I know where I need to reduce and where I need to adjust. If we want to be driven, and this is what I teach to do, if we want to be driven by our temporaries, then we need to know what our finals are pretty much going to look like before we prep. Otherwise, you can end up under prepping or over prepping. Yeah. So we need to create some kind of a mock-up before we actually start the prep. So we either have, let's say, a wax up, which I then would put in, and then we modify to look right. So we haven't touched the teeth at all, generally additive in most cases, right? Otherwise, we will have tried to make the case additive first, like ortho or whatever it is. And then prepping through that with depth cuts and then prepping in that way. So if we do it like that, then we're knowing we reduced everywhere we need to reduce. If we go and we just blanket prep each tooth like a veneer prep, we'll have definitely over prepped. So if you prep through your mock-up, then you know you know where your final needs to be. You're reducing sufficiently for the material, and that's really important. So that can be done. And then once you've retracted, taken your impressions, scan, whatever, scanning, sorry, anyone digital is not good enough for minimal prep or no prep veneers without contacts broken. It just is not good enough. No matter what a lab technician or any dentist that says that, you're doing the number of cases I'm doing with veneers, I have had the opportunity to try that method and not try that method, and different labs, it's not there yet. It will be there, and it's very good for broken contacts and clear margins, but I'm sometimes not even putting a margin on, and I'm definitely not breaking contacts in most cases, so unless we have to. So it struggles. So I still rely on traditional impressions.
That's what we want to hear on Impression Club Live, to be fair. So give the people what they want.
Traditional impressions, DMG, honeycomb, generally,
yes, beautiful stuff.
Yeah, amazing stuff. Making sure we match up whether we're using fast or not fast, because the light body and the heavy body need to be, or the medium body need to be exactly compatible. And then once that's done, then we take all of our records, and then we make the trial smile by hand, and that's flowable composite. If the teeth have barely been prepared, so I mean, I have a very, very rubbish picture here. If the teeth have barely been touched, okay, then we're just adding straight over. Just adding and adding and adding until things look right. And that's it. If the teeth have had some preparation, we will have a pre-op impression already. So, or if we have existing veneers, let's say. So any existing veneer case, like this case, let's take as an example. Here, he's got bridges and all that, so I would have a pre-op of that. I would then remove the bridges, do the preparation I need to do. I'd put the pre-op back in Luxatemp. So he would then have a temporary that looks exactly like this pre-op. And then I would adjust that to look like my temps over the top of using them flowable. So that's the process of doing the trial smile with Luxatemp and Luxaflow, and bonding the trial smile onto the teeth.
This is what I was amazed. They didn't. No one asked about temporization, which is like normally it's what everyone panics about, right? So yeah, let's go for sort of temporization.
Spot etch, Gluma, which is one of my favorite things.
Yeah.
Gluma is glutaraldehyde with a methacrylate. It's made by Kulza. Very, very good for desensitizing teeth. And has some disinfectant properties, supposedly re-wets, and so you're going to get better bonding. It kind of brings the collagen fibers up a bit again if you've over dried, which everyone over dries pretty much. Generally, we can't help it. So that I use that, and then I will use Optibond FL2. So not FL1 and FL2, just FL2, because it's just bond, no prime. So then we have either the Luxatemp or the flowable over the top. So now I know my bond is going to stick to the resin when I remove the temporaries, not to the tooth. And this way we also are getting a little bit of sealing. Okay, we're getting a little bit of sealing up of any dentine.
I was going to say, Stuart did ask about IDS, so do you want to? He's not even here, so you can say whatever you want about it.
Stuart knows the answer, because Stuart's done our course like years ago, and now he's like incredible at his work and his bonding and stuff, and he has follows a lot of that Pascal Mania IDS stuff. If I'm doing multiple units, generally minimal preparation, I will only have little bits of dentine, maybe on the insides of the edge if there's been a bit of wear or something like that. A very, very tiny amount, but I have a halo of enamel right the way around that. So I don't need to worry about that tiny little bit of dentine not sticking. So if you think, why do people do IDS? It's bonding, it's sensitivity. I'm controlling sensitivity by sealing my temps and the Gluma and not over prepping. The second thing is we are going to get enough retention on the final restoration by having enamel right the way around. Now, what if we don't have enamel right the way around? Well, then that's not a veneer. Then you've got a different approach. We're talking about veneers right now. If I did IDS on my veneers and I would end up with everything sticking unless I use Vaseline, which is what they advise, and then I'm not able to test my occlusion in the temporaries. I'm not just putting temporaries in just to tide them over. I'm putting it to realistically test the function. So I need to know that is sealed. And if I have Vaseline to stop that bond then I'm going to have that affected in the occlusion. Then I don't know, is it chipped because it's weak, or is it chipped because it's occlusal factor. So that's why I don't do it. But I manage to avoid sensitivity and still get bonding by sealing the temps using those techniques. And then that'll be it. So, and then we'll adjust the occlusion to be what I want, and then the patient will leave with those temps, and they'll live with that.
And then living with that for how long?
A week before we see them again. So let's take this case before temps final.
That's some good temps.
This is giving us our information. Okay, so I want parallelism with the lower lip. I'm looking at it from all the angles. You know, is it flowing here? That's too long, right? I can see that in my temps. You spend time doing this, you'll be tired by the end of the appointment. And so what you need to do is you need to have a look at it with fresh eyes a week later as well. You know, and so the patient also is overwhelmed by this change. And so they need the time, come back. And what I say to our patients is, in a week, we can have a rational conversation about this. If we have a conversation about it now, it's totally irrational at both of our ends. I'm emotional about it because I've worked so hard on it. You're emotional about it because you can't get used to it. So we're just not going to have a good time. A week later, we're over it. We can now look at, what do we need to tweak? So, okay, in this case, pretty much nothing, right? We didn't need to tweak anything. But if we look at a case maybe where we're thinking about tweaking something, let's take this example. So that's the initial situation. Patient wanted her front teeth to disappear. The answer to that is to build out the others in this case, create a similar length. Patient came back a week later, I miss my front teeth. Okay. And this is what happens. And if we had just had one go at this, we could have made something that looks like that, stuck it on, and then what? It's too late. Patient has not had time to get used to things. So your temporaries have to be diagnostic. They have to look like the final result. It's no good giving someone temporaries and then saying, oh, it's just temporary, it'll be all right. So this has got to form part of your design. So what I decided to do was just bring back her dominant centrals, but just to a lesser extent. If we hadn't done this, we wouldn't have had that information. You know, similarly here, we wanted to widen the smile. This is moving away from golden proportion and all that stuff. You know, this is not classically smile design looking case. Yeah, the centrals are too long, they're too thin, the teeth are too skinny. The rest of it's too flat. But that's what you decide on once you do this. That's where you realize how to get the result as bespoke as it can be, and that's really what it's all about. Rather
so
than,
you've already done your working imps at this point, and then you'll just bring them back in a week later. You may be adjusting the temps. Say they're then happy after this week, and you haven't needed to adjust. Are you then taking a record of these to the lab, or
so I will take a record of these on the set. So we've got to the point where we can take a record on the prep day, knowing that there's really not going to be changes at the trial. Okay, so we take the record already, I send it to the lab, they'll have temps 1 impression. If I see the patient and then I have to make some significant changes, which is very unlikely, then I will make the change on that visit and I'll re-impression or scan. That's fine to scan for. Send that to the lab and then they'll have temps 2. Because it's important for the lab to see the changes I made from temps 1 to temps 2, so they don't make a mistake. The other mistake that you don't want the lab to make is use the wrong impression. Okay, so because they make a putty stent and build into that, right? If you're layering, you're cutting back and layering, you're layering into your temporaries. So it's really important they are right, especially that's beveling the insides of ledge and stuff as well with that. So they need to. I like them to have a stage by stage changes. When we have a big rehab case, this is more relevant because we're tweaking occlusal surfaces and we're tweaking binding. So we would record that as we go along. So then they have
Minesh has just turned up and he says, hey guys, he misses us already. It's only been 3 days, mate.
Minesh, I miss you too. I have focus all over my house at the moment, all the brochures so I maybe don't miss you as much as you miss me because I'm thinking about you too much.
Perfect. So then you've once you're happy, then they've got this stent, and then is there sort of, I guess you're going to have cases where you maybe send them away for a second week to try it again, but hopefully not too often.
It's extremely rare. Sometimes I insist on it in my expectation management at the beginning of the case. So I'll say, you are going to need 3 appointments because your expectations are at this level, and I can tell that you're going to struggle with this change.
Yeah.
And usually we don't need them, but if we need them, they're there. And that just comes down to just understanding the people's personalities, because generally it's more of a management of getting them used to it, rather than continually tweaking. You can get into a real mess if you're just kind of responsive. And I don't like that generally. Like, you know, if I'm working on anything, I really don't like reactive stuff. I like proactive things. And if there is something we need to do, I'll step back and and think about it and then make a choice. And I don't want to do my dentistry in that reactive way. So the more I want to change this, or okay, change it, you know, we'll end up in a real mess. And then sometimes if it's such a significant change, then really we need to re-prep, don't we? Because what if we want to make the tooth much shorter and you haven't prepped enough? And that's where my technique is a little bit difficult for some dentists to kind of immediately copy. And that's why I would say that the best thing to do is to get additive temps, get the patient on board with that, you know, get them used to it, and then go back and temporize. Then go back and prep through, rather than doing it my way, which is already getting that commitment. So there's various, you know, ways you can do it.
Now, we touched earlier on where you sort of said that if you're, you know, indenting or whatever, you know, it's not veneer technically or things like that. So we had a few questions on prep designs. One sort of on that I'd like to touch on is proximal restorations. You know, we see it all the time, lots of centrals, little mesial distals, or whatever it is. What's your thought process? Are you replacing those and then, you know, putting them back in and then having a facing? Are you incorporating? You removing them, incorporating into a design? How do you go about that?
If you have a proximal restoration and and you don't need to prep that tooth back, then it's cool to leave it and have a facial veneer, right? That's fine. If you don't have undercuts and you're getting a knife path of insertion, and things are fine. If you have proximal filling, and you need to prep that tooth a little bit for whatever reason, and you're going to have your margin of the veneer on that filling, you've got to break the contact. There is no way around it. There is no secret. I've tried to look at different ways of trying to do this. There is zero. If you want to wrap that around and you want to seal that filling into the veneer, or you want to have a predictable margin, then you are going to have to break the contact. There's no way around it, sadly. Okay, but then again, we have to weigh up. We're so obsessed with minimal preparation that we can sometimes do a disadvantage to our patients. If I say, oh, I'm going to minimally prepare and I'm going to accept that margin on that, the patient's going to have way more issues long term and have to replace that restoration. There's going to be leakage, and what if they get an issue with the filling? Then we're going to drill around the back of your veneer, and what on earth? It's going to be a mess. Than if you just broke that contact, just enough space to get a path of insertion and have the veneer seated. You know, that's not going to give them as many issues long term. So there's that balance of being minimal but also being predictable and long term. Yeah, there's no secret to that one.
Perfect.
For example, look, I have a case here.
There we go. Oh,
okay. Look, this is what happens. I get veneers delivered to my house.
This is proper preparation. I love that.
No, it wasn't. They just got delivered just before we started because I have to fit them this week. And this is kind of what we're working on. So if you look at the centrals, the contact is broken. Okay, there was a gap there. The patient had some IPR, some Invisalign done with the dentist. The case was then, I think that maybe there was some residual spacing. And then we had a situation where there was, I'll show you actually.
We got it.
Yeah.
Sweet.
There was, see these sort of composites? Not a BioClear technique. This is an addition of mylar strip kind of composites, upper and lower, causing gum issues. It's compressing the tissue. So I think what's happened here is the Invisalign was removed and this was just done, right? And I think there was a residual space. So by the time we took all this off, and Dr. Lydia Sharples spent quite a bit of time in the practice, really meticulously removing all this bonding, and the gum then was given chance to heal after the patient had some perio treatment. So we're really kind of going back to basics. If you look here, there's already a bit of a space, and there was a proximal filling. So I had to make a decision as to what I do with that, and my decision was to, break that contact, well, open the contact a little bit more. It's already naturally broken, right?
Yeah.
To then allow that to wrap around. So that then is going to seal that a lot better. But generally, you don't want to break a contact unless you have to, because then papilla is a little bit more unreliable long term, and you don't want overhangs and things like that.
And that case there almost then covers the other question we had on prep design, which was diastoma closure. Any particular things that you look for or consider when you're trying to close diastomas with veneers?
Path of insertion. So if I go to, let me try and find something that would help.
I saw Lydia was on for that whole time that you spoke about her fantastic work, so that's nice.
I can't work without these people. I can't tell you how much I rely on the rest of the team for so many different things. So I'm really I'm grateful to all of them. What were we talking about? Diastoma. Okay. So, okay, let's look at this one. So
I love how well prepared you are. This is fantastic.
I just have a library of loads of stuff here. Okay, diastomas. This case has got multiple diastomas. Okay, what's the point in doing any ortho here? Where the space has got to go somewhere. If I try and push it this way, you're going to have a midline shift. Try and push it this way, there's a midline shift. Can't do anything with ortho. This has to be restorative. So if we have a diastoma, what are we doing here? Well, what I need to look at is this line. Let me draw it. One sec. So I have to look at this bit here, and I can see that is an undercut there.
Yep.
How is a veneer going to sit there? If I was doing composite bonding, it doesn't matter. But if I'm seating a veneer, I need this to be parallel, and I need that to be parallel. So you're going to need to take a soft flex disc and just do that. Over here, ever so slightly distal, we're going to need to soft flex and do that. And this is prep by soft flex, right? This is not, and people never say, oh, why do we not talk about no prep ortho or prep ortho? If you're having IPR, that's prep.
Yeah.
So people would like to say no prep veneers and prep veneers are bad and all this sort of stuff. Well, we're talking about sometimes in situations like this, in most cases, the tiniest amount of preparation, you could actually call it reversible, because you wouldn't even see it or have any sensation of sensitivity or anything if you took the veneer off. But that's the kind of thing you need to look at, path of insertion for diastomas. Yeah. The other thing is soft tissue. If you have to close that, are you going to end up with a black triangle? Well, how far are you going to need to close it? So when you're prepping, or you need to have your finish line subgingival in that mesial area. It's got to go into the gum line. So sometimes if we have a frenum, I'll do frenectomy with the laser, or I'll actually trough in that interproximal area with the laser, because you can do that a little bit more interproximally with soft tissue lasers than you can buccally. So that's what I'll generally do. So then we'll retract that, and we'll get a really crisp impression of that, and we'll be able to then create a margin at subgingival coming out, and we have a really nice emergence.
Well, that's where Harry's asked thoughts on the Pascal mini wing concept and things like that. Is that more for crowns? Is it a similar sort of thing? With that
it's the same sort of thing, isn't it?
Yeah. So there you go, guys. You should have been at the BACD to catch that. Karina and Lydia both saying you're welcome and thanks for the shout outs to the team. I've missed a bunch of other messages. Well, perfect. I mean, that's that on diastoma. And well, while you said about sort of discs and things like that, any particular veneer prep kits or burrs or anything like that you like? Karina and Lydia are just having their own chat, by the way, about how we can't live without you. And
I'm going to regret saying that now.
Yeah, you're going to get in the neck tomorrow.
Okay, burrs. Okay, so I'll tell you the reality of it. I qualified and I had a really amazing BT trainer in Cornwall, really like the standard NHS practice. We didn't have a lot of materials. So I got used to using, just generally, pretty much not much. We had like 2-3 different types of burrs and that was it. Then when I moved back to London, I had a dentist who's lovely and still a friend of mine, who had come from abroad, who was my nurse because she was getting the hang of.
Yeah.
Get rid of these. I think I need.
We got you. Ooh. Yeah, all good. Thanks for going.
Yeah, so she's, great friend and love her to bits, and we had such a good time. But we know dentists don't make the best nurses, and so I basically had to fend for myself for a whole year. So I got really low maintenance. I really got low. I managed to be able to get the best out of what I had. So now, if you look at my burr kit, there's nothing on there. There is a very thin prep burr for interproximal areas. There is what people know as the Big Daddy burr for reduction or incisal edge or something, and there is a nice chamfer thin burr for prepping margin, and then I will have a needle burr or a mosquito type burr, and mainly that's for my temporaries. Okay. So that is all I will use. There's no particular kit. Buy whatever you feel works in your hands. But generally, we're using chamfers or no margin at all. So yeah, it really doesn't matter. Just don't get anything too coarse. You don't need to really massacre it.
Yeah, we just had another question about prepping, and we did actually have it in there, but I've missed it. Gingival recession. Are you prepping? Where are you finishing your preps? Are you chasing it? Are you going subgingival?
Okay, this is really important because
Good job I didn't miss it then.
Where veneers have been placed for about 20 years, right? So I'd say about 10 years before I was there. And I have the pleasure of then seeing things come back at 5 years, 7 years, 8 years, 10 years, 15 years. And where do we see the failures? We see the failures at the gingival margin where the veneer was bonded to dentine. Okay. So I just don't do it. I'll show you an example, actually just a recent case. This lady, actually I've shown you the after of it already, that's here, but these are the retracted shots, okay? This is the situation here. I'm not happy to prep beyond this line here because I'm not wanting to stick my veneer on anything that isn't enamel, because then that I know is going to chip and fail over time. You will have totally different strengths over here and over here, and you will find that fracture. You'll also see staining over time. Not that it matters up here, but it's leakage, right? So that's not good.
Yeah.
So I'll consent my patients for this, and I do this all the time. If it's a high lip line case, then we're going to need to look at grafting.
Yeah.
So I'll get the veneers in the right place and then we'll graft it. So that's a case where I would not prep into dentine. This was these were her temps, and then these are her finals finishing there. Okay, this is healthy. It's cleansable. There's going to be no long-term issues with bonding. And she has the option now of grafting this. And I always push that as an option because it is the right thing to do, to seal that up. So that's what I will do. I will not take it up. Now, in any cases that you see that you think I have done that, that's not a veneer. That would be like a wraparound restoration of some kind. So there are some crazy ones where, there's root exposure and all this sort of stuff, and we've made it look like teeth again. Those cases are 3/4 crown cases. There's no other perio treatment or anything else that can be done. We've just got to accept that as a heavier prep, and it's not a veneer case. And then you're dentine bonding or doing different things there, but not for a veneer or a minimal prep veneer. Don't take it up to the gum line.
Yeah. Perfect. We've done preps. I like how before as well we were chatting, be like, yeah, we'll keep it short, 45 minutes, and we're just absolutely flying through. So I think there's going to be a part 2 as well. I can feel it. But let's do some fits, because this is what all the questions were about. And you've already answered half of it by saying you're never trying to bond to dentine anyway. Interesting question from Gary there, the cosmetic dentist, just saying, general thoughts on pink porcelain?
Okay, pink porcelain can be really, really a lifesaver.
Mm-hmm.
So I have the shade guide, you know, the pink shade guide, and we try and get it to match. Essentially, just choose the lightest pink that you possibly can. In most cases, that's what works. I do use it sometimes for implant cases where they have a little bit of a high, using a bit of a flange, essentially, up there. Expectation management. You know, it's not easy to make that look good. On a veneer, if you're needing to use pink porcelain, chances are that you are covering dentine.
Yeah.
Then you're asking, why are we covering the dentine?
Mm-hmm.
Why are we not grafting that or trying to graft it? So that's my take on it. I do use it though, not all the time, but I do use it to get me out of trouble. Mainly implant cases, to be fair.
Yeah, so not necessarily for veneers. We've had another question there as well, sort of where you've got in-standing teeth. Patient doesn't necessarily want ortho, but would like the profile flush with the neighbours. Obviously, you're looking at blowing things out and things like that. Any tips for dealing with that?
Yeah. So let's see. I mean, does this qualify? Maybe not. I mean, this is a crazy class 3 one, right? So, but generally, all these teeth have been brought out on this side. Okay, so yeah, that has been brought out a bit, but this has been brought out a lot. But the way to avoid those thick, you don't want thick incisal cervical areas, because you're going to get gum issues, you're going to get all sorts of problems. So you want a flat emergence. Let me see if I can try and find you something.
It's going to be more about disguising, sort of.
Yeah. So let's take this case. That needs coming out. Okay, but that doesn't look bulky because this cervical area is flattened. If we flatten that emergence and you bring that out, and you put the gum line in the right place, it's going to look good. If we have a cervical step here, where sometimes we do see that in veneer design, then you're going to find that that's going to look bulky. And even in this tooth, that's been brought out. Okay, over the top of that, that's come out. So in a case to look where a patient doesn't want that ortho, such as this case, then first you'd have to accept that we're going to have to reduce a little bit here. But the rest of it doesn't actually need a lot of reduction because we're building everything out to this position. So, but the way we're doing it is by bringing it out and then we're curving in.
So it's about managing that emergence to not.
It's managing emergence. Yeah, totally.
Perfect. So then, day of fit. What have we got? Well, first off, it's something we could have covered in maybe prep and impressions as well. Gingival management, cord, expansion pastes.
The best paste,
rolled up PTFE.
In my mind, is DMG retraction paste. X-Facil is fantastic, but you need that special gun for it. And then if someone's using it, it's in autoclave, it's like a whole hassle.
But
DMG retraction paste goes into any composite gun. So that's really good. It's also green, so you can really see it, so you can clean it properly. I use that quite a lot. I'm keeping most of the time the margins slightly supra or equigingival. So it's not going to be that difficult to get a good impression of it. We may not need to cord those. Then if we're using cord, it might well be if we have subgingival like that. You don't think you're going to get it through. But I'll generally retraction paste first, see what we've got. Sometimes it works really well. We work quickly. We can get that crisp impression before we need to cord or anything. Yeah.
Perfect. And then you've placed it all in, or you've tried your veneers in, trial pace and things like that.
No.
One of the questions we had was expectations managing at this point.
Use a try and paste ever, because try is slightly inaccurate. It's also just a nightmare to clean, and so I don't want to use them. We should not really be relying on our cements to try and make, unless you've got a really dark tooth and you know that you have to use like opaque on that, fine. But we shouldn't really be relying for multiple unit veneer case, the color to match, because you're going to use all sorts of different neck, all these different shades you can get. So I'll water try and just for suction. And I'll make a decision on cement within like a second. I'll look at it and I'll say, we need to warm it up a bit. And it's a medium translucency, so it might make a difference. Then I'll use something like A1 or something. But if I think it looks perfect, then if it's a low translucency, then I'll just use clear. cement. And if it needs to be brighter, then I'll go either with a white or a high opacity if we need it. Generally, my cements of choice are Vitique by DMG, like your working time. You don't need to stress. Having said that, I place them super fast because I don't want to. I don't want moisture and any kind of other issues. And then the other use for dual cure is a Verilink. Verilink's just very reliable. Works really well with the Excite bond. Now, flowable composite. Sure.
Yeah. Those are the things. It was flowable, heated, classic cement.
Heated is fine, but your restoration needs to withstand. You need to place that restoration. Twice I have cracked a super thin veneer.
Yeah.
Red, like so. Happened to me twice. I mean, it's not bad going, but there's 2 more times than I'd have liked. You're just going to increase that chance if you're using heated composite for veneers. So flowable composite is probably better as long as you can light cure through those veneers. So there needs to be translucency, and they need to be very, very thin. And so it's good because actually you get that color stability with the flow, and you get that that slight filling. So the fact that it's filled means that it will seal up any kind of areas. But I mean, if you're relying on flow to seal things, then the fit's probably not good enough.
Yeah. So your majority, you're going for your sort of more classic sort of resin cement style.
Yeah.
Fine.
And light cure on the thickness of the restoration.
Yes.
Right.
Perfect. We had a question earlier. I hope he's still on for Garrett there, saying when you're redoing veneers, any concerns with bonding strength? Are you doing anything differently at that point?
So it's very rare that I'll have a case that I take the veneers off and there's really minimal prep. Sadly, that's the situation. So I will generally turn that into like a 3/4 coverage restoration or something like that. When you are replacing veneers and you find there's a decent amount of enamel, then that's great. That's the idea. That's what I am building in. So when I say to my patients, I'm trying to do this minimally, it means maybe you'll have to accept a little bit of compromise aesthetically. I might not be able to push this back or do that. But it means in 10, 15 years time, maybe 20 years, if because we've done things right, then you could have veneers again because you're going to have a load of enamel left, rather than having to then move on to a bigger restoration.
Yeah.
It's always more unpredictable replacing existing stuff.
Yeah, of course. Well, I mean, that, believe it or not, was every single question that we had coming through. So that's awesome. Guys, if we have any other questions, please do pop them in. But it sounds like, Sambad, we're going to get you on for a part 2 at some point, if you wouldn't mind. One question that I like to do, just while people are maybe entering any other last ones, is just ask you a bit of a general one personally, which is, is there a top tip you got for young dentists, or is there something that you do now or know now you wish you were doing, 5 years ago or something sooner, anything like that? Doesn't have to be about veneers as well. It can be in general.
Right. And I think that's the biggest message. I think people still see myself and anyone else doing cosmetic dentistry to a certain level and think that it happened like just in one day. It never stopped. And we had a pathway through BACD, which we kind of followed. We found the right people to learn from, people who were doing those things, going on the courses. People do that. Look, if you're doing a lot of implants, go on a course where someone's doing loads of implants the way you want to do them. If you want to do dentures, they've got to come to you to make dentures.
They've got to come to the BACD next year.
Looking at that, those individual clinicians that you see and you admire their work, go to learn from them. That's the first thing. Nothing is a waste of money or time. I did loads of implant courses. I spent 2 years and spent a load of money and traveled everywhere to learn about implants. I now can treatment plan, which is incredibly useful, what we're doing, but I didn't place any implants. But because I did that, I can now do it. So nothing's a waste. You may feel like you don't want to pursue that, but that's okay. It makes you a better dentist. But yeah, take your time and, find your niche. You don't have to be doing what other people are doing. You'll find something you like and be proud of that. It's okay. But meet people, network. If you're young, at BACD Young Dentist Day, and you should be at the Young
Perfect.
here with
Yeah, there we go. So I don't think any more questions coming in, so I can let you escape. We had lots of people saying, definitely, please, part 2. We need more of this. Karina did preempt what you'd say, and she said your thing you wish you'd done earlier was hired her sooner. But no, it sounds like you've got a great team. And you've mentioned you've been very good and not plugged anything too hard apart from DMG. No sponsoring. But you've mentioned courses, your education. Just give us a little idea about that in case you're one of the people want to come and learn from.
Yeah, I mean, look, we run Bespoke Smile Academy is something we started some years ago now. And what I found was that there was a lack of hands-on and close education, porcelain veneers and indirect restorations, smile design in this new way of doing things, not the Hollywood way or the old-fashioned way. We lack of that. So little 2-day course and that kind of thing. And I realized that actually that's not enough because
you mentioned day 4, right? So what's it look like now?
I scrapped the 2-day one because in 2 days you cannot understand, and there's been a million questions on bonding, how to bond the veneer on tooth, right? I think this is, we should have covered this earlier actually, I forgot to mention.
Part 2, there we go.
Just how most of the questions were about how to stick the veneer on the tooth. You could stick the veneer on the tooth with GIC and probably stay, let's be honest. If your occlusion is right, and this is the point, the failure of restorations is not always down to the bonding and is actually rarely down to the bonding. It's pretty much always down to the occlusion. So focus should be on occlusion and not about, okay, the bonding is important. We all know how to bond teeth. This is the focus. So I had to introduce that. So first 2 days on treatment planning, occlusion in a really super simple. When you see this, you need to think this, and you kind of categorize your cases. And that way you can start to have realistic. And the thing I find is that a lot of occlusion courses, you'll come out and you'll be more confused than what you were when you get. And you may have done 1 or 2, and each time you think, oh God, I get it, and then I don't get it. And also you come out thinking every patient needs a rehab. Of course not. You've got to find ways, and that's why some people say, oh my God, how did you do that? So because I have a way of getting the result without having to overdo it, without having to treat 20 teeth or put them through rehab. How can you put a 20-year-old with wear through rehab unless there's no other option? Of course not. You need to have tricks to manage that using a veneer, let's say, or even composite. So we focus a lot of that at the beginning. So that is my treatment planning number 1. Where do I need to get this patient occlusally? Then we need to do the treatment. We need to do the trial smiles. We need to do the prep protocol. Then we need to know how to review the trial smile. We need to know the communication to patient management. And then we need to know how to fit multiple units easily and predictably. And then we need to know how to manage the occlusion at the end and what maintenance pitfalls and all the things that go wrong. And that takes 6 days to do over 3 weekends. So we run that every February and we run it every April. In February, people can bring their own patients and they can do, people bring family, sometimes friends, and it's really amazing to do that. Or a patient from their own practice. And then in April, I treat and people observe. But there's a mix of ways of doing it because people have different. You can come along and you can observe it all, really take it in, go back to your practice and come back one-to-one with the patient, or you can hands-on, do it with the other dentist, with me, with the patient, or you can just observe and learn all that and do the hands-on the lasers and stuff and things like that instead. So yeah, we do that twice a year, and it's a joy. It's a joy for the whole team. And Karina, Lydia get involved. All our nurses get involved, and it's we're incredibly proud of it, and we love all the dentists that come through. People travel from all over, and that's how Lydia and Karina joined us, because they did the courses, and the team were like, you've got to get these 2 in.
Oh, amazing.
So we did. So it's great. It's great, and it's good fun as well.
Yeah, sounds fantastic. But let's leave it there. Sounds like part 2, occlusion for veneers, coming soon. I don't know. At some point in the new year, maybe.
Fun that would be. So probably more interesting to do next time.
Well, we'll work something out, but I think definitely a part 2 would be great. Thank you so much for coming on. And yeah, I mean, we talked a lot about expectations, but blew them away tonight, I think, bud.
Well, thanks to everyone for listening, giving up your Tuesday night.
Yeah, 100%. Thanks everyone for stopping by. We had tons and tons of people on tonight, which is great. Next week, we're going a bit non-clinical. I saw Rabia was on at some point. We're going to chat about journey into some practice ownership and running and things like that. So ease the month out with a bit of non-clinical stuff. But yeah, Sam, Bud, I'll see you around. Hopefully,
that's the hard
event
stuff. The
soon.
non-clinical stuff's the hard stuff. All this is easy.
Well, I'll see you checking in next week then, Bud.
Yeah. All right. Thanks, Rupert. Thanks,
Cheers,
everybody.
man. Thank you
See
so
you.
much.
Have a good night. Yeah. Bye.
Cheers, guys.